children have seizures, just like adults can have seizures. And often, well, thankfully not that often, we go to patients, young patients, children with epilepsy of varying severities. And so at the far end of the scale, people might have gone, I never know how to pronounce it, Dravet syndrome or Dravet syndrome. But there's certainly a few patients in my area with that. And so there are these syndromes that lead to a lot of neurological dysfunction. One of those is that they have recurrent seizures, and that, as well as other neurological dysfunction, leads to developmental delay. Those patients are often easy to recognize as patients who are having epileptic seizures and require treatment, and often the family will be very aware of that. On the other end of the spectrum, I guess, the more common presentation is febrile convulsions. And in fact, I've been to two in the last 10 hours at work. and so the mechanism there is when a child, an infant, it's normally between the ages around 2 to 5, get a sudden spike in temperature. So normally they'll have some relatively mild illness, like both the children I saw today had bronchiolitis or some respiratory infection, as have I, as you can probably tell by my voice, as has my child, as has my wife. But so they have some sort of mild illness. It'll cause a spike in temperature, and that rapid increase in temperature will, through a mechanism I don't understand, lower their seizure threshold in the similar way we spoke about, and that will predispose them to having an epileptiform seizure and therefore convulsion. Often that looks very scary. They don't occur commonly. So when you attend these patients, often it is the first time it's happened. Very scary for the parents. They appear to stop breathing. They don't necessarily stop breathing, but where all their muscles tense, their intercostal muscles in their chest also tense. That causes them to forcefully exhale and make a loud sort of shouting noise, and then hold their breath out essentially, and then go a bit blue because they're holding their breath. But that's a fairly common presentation for febrile convulsion. Thankfully, they almost always terminate very quickly in 1 to 2 minutes. And so that is an epileptiform seizure, but it's not from like a significant disease process like a stroke or a brain injury. And very rarely would that happen twice from the same illness. And so those very rarely would lead to a diagnosis of epilepsy, because, as we said, a diagnosis of epilepsy is when you have seizures repeatedly, at least 24 hours apart. So a febrile convulsion is a seizure and a convulsion, but it's not associated with badness most of the time. The guidance is that those patients go to hospital, and certainly if it's their first one, because whilst most will be fine, you don't want to miss that one patient who's actually having their first presentation of a more sinister illness. The treatment for those patients is most of the time, by the time you arrive, if you're in the ambulance service, they would have stopped fitting. But the treatment otherwise is exactly the same. If it lasts longer than 5 minutes, you give a benzo. If it lasts longer than that, normally enhanced care support will give second line, third line drugs. Giving like antipyretics won't stop the seizure. So it's the rapid increase in temperature that triggers the seizure. Once the seizure has started, reducing the temperature won't stop it, because it's essentially like a switch. So the treatment is still the same. You give them the anti-seizure drugs if they're still fitting. And then afterwards, when they're stopped, if they're still hot and uncomfortable, then you can give them antipyretic. But it's not the first line treatment. That would be the same. Functional seizures in children, I won't even try and address, because I don't know anything about it. But in my experience, I don't see that. And I think that's because part of the reason people develop functional illness is because their mind matures as they grow older, and their subconscious as well as their conscious learns how to adapt to the world around them. And that's how the subconscious develops these mechanisms of essentially imitating what looks like an epileptic seizure. So I think that's probably the reason I don't see many children with functional seizures, or certainly young ones. Having said that, I do see quite a lot of troubled teenagers who have functional seizures. But again, often associated with childhood trauma and things, that contribute to that in later life. hopefully that answers it.
Super, thank you. So Benjamin's put on, uh, does having high flow oxygen not alter the end tidal CO2 reading as it's blowing air over the sensor? I can't. I read something recently that it alters readings. Can't remember where though.
Yeah, so I probably should have explained that a little bit more. Like theoretically and on scientific first principles, yes, it would. And lots of things would affect your end tidal CO2 number if it's not a closed circuit. So if you're intubated and you have an inline CO2, air goes past it one way and past it the other way, essentially. And so it's a fairly accurate indicator of the end tidal number. If someone doesn't have a closed circuit, so you put like nasal specs on, lots of things would affect the number. Oxygen might, I don't know to what extent, but also if people are predominantly breathing through their mouth and not their nose, you might get a different mixture of gases passing over the sensor. And so, whilst whilst the number is probably not that reliable, maybe a trend is, but the number itself is probably not reliable. What it is very useful for is the respiratory rate. And it will tell you, it will alarm if patients become apneic, and that won't be affected because either air is predominantly going in or is predominantly being blown out, and the sensor will definitely pick that up.
Super. So Katie's mentioned technology regarding detecting seizures. So technology progressing that there's a range of devices on the market to detect seizures, tonic-clonic only, that Katie's aware of. What do you think of epilepsy/seizure alert devices such as wearables or sensors on beds? I believe some devices claim they can anticipate a seizure occurring, but not sure how accurate they are.
Yeah, so I don't know much about developing technology, but I see a lot of patients with these seizure mats and things. I think they're good. Generally, as I say, most people who have an epileptic seizure it will self-terminate quickly. There are obviously patients with more complicated epilepsy and syndromes that lead to seizures, who are predisposed to having prolonged episodes and requiring benzos to terminate these episodes. And often people are prescribed their own midazolam. So certainly for those patients, the high risk periods are obviously when they're unattended and unconscious, so essentially asleep. But for patients with care needs, they might have seizures and not be able to seek support effectively themselves when they feel a seizure coming on, whatever. So definitely those devices are very good. I think the most impressive device, if you can call it that, from some CPD I've done in the past is seizure or epilepsy support dogs. I remember we when I was a new paramedic, we had a talk from someone that trained support dogs, and she was saying some of these dogs when they're fully trained to recognise seizures, there's there was a girl on her caseload whose dog would be at home while she was at school, and it would lie down at home 5 minutes before she had a seizure at school. So how they do that, I don't really know, but I'd get one of those if you could.
Absolutely. So Margaret's asked a question with regards to uh, giving midazolam for a seizing toddler who's already prescribed Keppra. Um, uh, would you give it if the seizing still 30 minutes later while waiting for an ambulance?
Yes, essentially. So levetiracetam works differently. I don't think the mechanism is fully understood, definitely not by me, but it works differently to benzodiazepines. So there might be reasons people have prescribed that and not a benzo. And obviously, if it's an allergy, don't give them benzo. But in lieu of that, I'll definitely give them 2 doses of benzo, and because they act differently. Also, what I didn't mention is the quicker you give the benzo, the more likely it is to work. Because as seizures continue, the GABA receptors get internalized and go into the cells, and so you have less GABA receptors available for the benzodiazepine drug to connect to. So yeah, any patient that's fitting, I wouldn't wait to give them a benzo, regardless of what other drugs they had. Quicker is better.
Absolutely. Lots of questions, which we've got to run out of time for. So I'll just pick up on another one. Alicia has put, should I pre-alert a patient actively having a psychosomatic convulsion? What are the risks of delaying hospital transfer, if any?
Yeah, so it's a really complex one, and that's why I'd encourage. Uh, like it's taken me years to get to the level of confidence I have now in managing these patients, and that is still not amazingly confident. It's just sort of more so than I was. Um, so it takes time to uh, learn the processes, but also meet the patients and gain your own experience. But it's a balance. The problem is if you over medicalize things and you cannulate people and you rush them to hospital, that can worsen the seizures. And there's cases in, as I said, I'd recommend Suzanne O'Sullivan's books, but there's cases in there and ones she talks about in interviews where patients with functional seizures have ended up intubated in ICU, and then every time they try and extubate them, they have another functional seizure because it's very distressing waking up in ICU and having a tube pulled out your throat, and then they get reintubated, and that comes with a lot of associated harm. And that's one end of the spectrum. But similarly, if you misdiagnose an epileptic seizure and sit and twiddle your thumbs in someone's living room for an hour, that could be harmful as well. So over time, you start to recognise and differentiate with some level of confidence, and that leads into your treatment decision. But essentially, I don't think there's any hard and fast answer other than gaining experience over time and reading around the subject and looking at the guidelines. The guidelines are much more comprehensive now. And I guess the final thing I'd say on that is even now, most of the time that I'm treating a patient with what I think is a functional convulsion and having a sort of consciously hands-off approach, I would still talk to our on-call consultant and discuss that with them, because you know you have to recognise the limitation of your understanding, and a decision shared is much better than the one you try and make yourself.
Super. Well, we are over time, but I want to thank Silas on behalf of everyone who's joined us tonight for tonight's webinar, for giving up his evening after a long day in work. So it's greatly appreciated. Thank you very much once again, Silas, for joining us. And I'm sure
Thank you.
we'll be tapping you back up for some more webinars in the future. So keep looking out for your for that message coming through on your email. But for the rest of you, thank you very much for joining us tonight. Greatly appreciated. Hope you've taken some learning out of what Silas has presented. Lots of really positive feedback in the chat, so we really appreciate that. Do ensure that you log on in the next couple of minutes to reflect upon what you've learnt tonight before it all disappears into your grey matter, or you go back to you go to bed ready for your shift tomorrow. If you are working, stay safe, look after yourselves. If you're like me, I'm going to be booking on now, so we'll see what happens in the dead of the night. But for now, thank you everyone for joining us, and we will wish you a very good evening.
Thanks for having me. Appreciate it.
Cheers, greatly appreciate it, Silas.